Good afternoon, everyone. My name is Dr. Ignacio Rivera. I will be lecturing today on the pediatric neurological evaluation. I have no disclosures for this lecture, except that part of the slides were from a lecture also given by Dr. Antonia Valencia. She's a pediatric neurologist in another institution. So the elements of a complete neurological assessment include the following: a focused clinical history, detailed neurological examination, and a focused physical examination in terms of uh, relevant parts of the PE that are important to child neurology. And some important concepts to remember insofar as the neurological assessment is concerned: that brain development is a continuous process. From conception to maturity, it is time-dependent, organized, sequenced, and highly structured. The acquisition of developmental and intellectual functions coincides with the neuromaturational processes in the central nervous system, and that the mode of presentation is age-dependent. And this means that at every age range, there is a different mode of presentation, depending on the maturational state of that particular patient. It's important to identify very early, if possible, these problems as far as both neurological and developmental issues are concerned, because of the potential for treatment and improvement through education and rehabilitative services. And when we attempt to do the neurological history, it's important to determine whether the problem is acute, chronic, static, or progressive. And these milestones we were talking about a while ago should always be recorded and determine if the development is at par, delayed, or regressive. And when we say regression, there is loss of skills over time, suggesting a neurodegenerative disease, such as inborn errors of metabolism. The review of systems should always focus on major childhood illnesses, immunizations and reactions to immunizations, and injuries, amongst other things, because frequent injuries may suggest hyperactivity or poor coordination. The temporal profile of the history will allow one to determine whether the patient's symptoms are constant, episodic, static, progressive, or resolving. A good example of episodic would be migraine. A, uh, a temporal profile of static disease would be cerebral palsy, for example. If it's progressive, then many times it's because of an inborn error of metabolism. Localization is also important to determine which part of the nervous system is involved. For example, if the patient presents with cognitive dysfunction or seizures, it probably points to the cerebral cortex or the gray matter. If the patient develops cranial nerve problems leading to, for example, double vision, dizziness, dysphagia, hoarseness of voice, disequilibrium, that could be a brainstem problem. If the patient has a sensory level, a dermatomal level, along with motor dysfunction, bowel and bladder dysfunction, consider a spinal cord problem. And if there is weakness, it could be one or and the entire part of the motor unit, from the brain to the spinal cord to the peripheral nervous system, and including the muscles. In the history taking, try to figure out also the effect of the problem on daily function. especially when it comes to cognition, behavior, and language and activities of daily living. The family history is important to determine, especially when it comes to patients who are suspected to have epilepsy, autism, other developmental disorders, some heredofamilial disorders, and do not be ashamed to inquire as to whether there is some level of consanguinity as far as the parents are concerned. This is relatively common in other cultures. No? And when your patient has epilepsy, important to take note of allergies, especially to medications. And always inquire the dose and the compliance of the patient if they do have medications, because they may be compliant, but the dose might be either too small or too big for their weight. And during pregnancy, during birth, and shortly after birth, take note of these factors: the age of the mother during pregnancy, the other previous pregnancies, how they went along, if there's any prenatal exposure to prescription or illicit drugs, alcohol, radiation, infections, and the timing of exposure as to what gestational age the patient or the fetus might have been exposed to. Maternal weight gain, fetal movements, and very commonly nowadays it's almost routine to have prenatal ultrasound screening for congenital defects. Labor and delivery history is also important. Gestational age, fetal presentation, APGAR scores if it's available. And as a matter of routine, always ask, in spite of maybe them saying, oh, everything was okay, ask if the patient required oxygen on delivery or shortly after, if there was any change in color, if there was any problem with breathing, if they needed to resuscitate the baby with ambu bagging or vigorous stimulation, and always review the baby book for the head circumference, length, and birth on a delivery. The APGAR scores are very important clinically because an APGAR score at 5 minutes of less than 3 uh, poses a 125-fold increased risk of cerebral palsy. Again, in review of systems, feeding history, if there were any problems with feeding, respiratory problems also, ambulatory coordination problems such as falls and clumsiness. So the first question here is there a neurologic disorder? And if so, where is the lesion? And what is the cause of that lesion? Some neurological issues that are relatively obvious would be signs and symptoms of increased intracranial pressure, meningeal irritation, focal neurological deficits, or developmental delay, arrest, or regression of milestones. So it could be anywhere in the nervous system, either centrally or peripherally. And when you do your neurologic examination, you start off with the usual vital signs, anthropometric measurements, especially when they're less than 2 years of age, general assessment, mental status, cranial nerves, motor exam, cerebellar exam, and sensory examination. Uh, Going back again to history, uh, unquestionably neurologic would be altered sensorium, seizures, language problems, and cognitive dysfunction. Other signs of increased intracranial pressure would be sunsetting eyes, stiff neck, sixth nerve palsy, diminished venous pulsation on fundoscopy, and in infants with unfused cranial sutures, increasing head size way more than the usual. So setting Sun-setting sign, is usually seen in patients with progressive hydrocephalus due to the loss of upward conjugate gaze uh, caused by increased intracranial pressure. And these are all well-known signs of meningeal irritation: nuchal rigidity, spinal rigidity, Koenig's, Brzezinski's, head tilt, and photophobia. So, in the general physical examination, you should plot the anthropometric measurements on the curve, plot it against the norms, whether it's z equals 0, plus 1, plus 2, or minus 1, minus 2, or worse than those. And always take a step back to look for any particular change in facial configuration or dysmorphism as far as the patient's physical features are concerned. And I always ask the mom or the dad or the caregiver if the child has any birthmarks, and then proceed to very carefully examine the child's skin, scalp whorls, and palmar creases, looking for cafe au lait spots, white spots, hyper or hypopigmentation. When it comes to vital signs, the temperature instability may be due to brainstem dysfunction. Fever or hypothermia may be due to CNS infection. The triad of hypertension, bradycardia, irregular breathing is called Cushing's triad and is the hallmark of a patient who is about to herniate because of increased intracranial pressure accompanied by altered sensorium. So just by the pattern of breathing, you can localize as to what part of the brain is already herniated. And for example, in Shane Stokes like this, you have very fast breathing with periods of hypopnea. And this is uh, Shane Stokes. And as you go further down the brainstem, you would see different patterns of breathing: central neurogenic hyperventilation, apneusis, cluster breathing, and ataxic breathing. So Shane Stokes often indicates bihemispheric dysfunction. Central hyperventilation is lower midbrain and upper pons. Apneustic breathing is mid to lower pons, while cluster breathing is lower pons and upper medulla, while ataxic breathing is central and lower medulla. So one part of the general physical examination, aside from what we already mentioned a while ago, would be looking for opacities in the eyes, um, unusual body odors. Let me talk about this very briefly. Burnt sugar, mousy smell, or sweaty feet. Burnt sugar is usually seen in patients, babies usually, with maple syrup urine disease. Mousy smell is associated with patients with phenylketonuria, and sweaty feet is associated with patients with isovaleric acidemia. And some dysmorphic features like hypotelorism, hypertelorism, inner epicanthal folds, slanted palpebral fissure, low set ears. So these correspond to different genetic abnormalities. And this is very important for you to remember. This comes out all the time in examinations, whether it be local boards or boards abroad. Hypopigmented patches, you see that with tuberous sclerosis. Cafe au lait spots, often associated with neurofibromatosis type 1. Port wine stain, Sturge Weber. Petechial hemorrhages on the skin, especially in an infant, is most likely CMV, a macular rash, lupus, while vitiligo may be associated with an autoimmune disease, including myasthenia gravis. So this patient in letter A has these typical cafe au lait spots, often seen in patients with neurofibromatosis, and these hypomelanotic macules are patients with tuberous sclerosis. So going to the cranial vault, the head, the shape and the size of the head may also indicate pathology. So you inspect, you palpate, and occasionally percuss. But oftentimes you get away with just visually inspecting and palpating. When we say palpate, you uh, examine whether the fontanelles are bulging or flat, whether the sutures are split, whether they are fused, or whether they are ridged. Macrocephaly is very big, a very big head, more than 2 standard deviations. A microcephalic head is small, less than 2 standard deviations, while craniosynostosis is a premature fusion of the cranial sutures resulting in palpable ridgy sutures, whereas venous distension or very prominent scalp veins suggests increased uh, intracranial pressure. A flattened occiput, on the other hand, may suggest a developmentally delayed child because the patient is unable to turn their head sideways, unable to roll over, so the head is basically just laying flat on the surface of the bed, and that causes molding and flattening of the occiput. Whereas a bulging occiput may suggest a Dandy-Walker cyst. A biparietal enlargement may suggest bilateral chronic subdural hematomas. So macrocephaly is greater than 2 standard deviations from the normal, may be due to hydrocephalus, meaning either communicating or non-obstructive versus non-communicating or obstructive. Or it could be megaencephaly, thickening of the skull, or chronic subdural or epidural hemorrhages. So this came from our textbook, Nelson's. This is congenital hydrocephalus. Note the very big head with prominent scalp veins. Microcephaly, on the other hand, is head circumference less than 2 standard deviations, often associated with congenital brain defects, congenital torch infections, perinatal brain injuries, rarely malnutrition. And if the head circumference is at birth is already below the 3 standard deviations from normal, there is a strong possibility that the patient might have or acquire intellectual disability in the future. So when you measure the head, this is the way you measure the head. You palpate the cranial sutures, the fontanelles, see if there's any swelling, any palpable masses, crackpot sign, which is not normally obtained anyway, but just focus on head circumference, the sutures, and the fontanelle. The normal gap of the unfused skull, as far as the cranial sutures are concerned, is only 1 to 2 millimeters apart. Whereas if you palpate the sutures and they are already ridged and raised over the scalp, that means there is premature fusion of the sutures. It could be one suture or it could be both sutures, thereby changing the shape of the growth pattern of the skull. And because the skull cannot expand perpendicular to the fused suture, it compensates by going more in the direction parallel to the closed suture. So this is scaphocephaly, the sagittal suture. So remember, scaphocephaly, sagittal suture is prematurely fused. leading to bone growth in the direction of or parallel to the suture, so it's from front to back, so it's like stretched out from front to back. So that's scaphocephaly. This is brachycephaly, wide from side to side. And in patients with cranial synostosis, uh, early surgery is indicated to prevent the brain from not developing normally, or also to prevent craniofacial distortion of the anatomy. And this is one more sign of craniosynostosis, the Harlequin sign, wherein the orbital bones are stretched like almost like ET in appearance. So scaphocephaly, brachycephaly. So try to remember which sutures are present in the child. The frontal bones are common pairs that separated by the metopic suture, and separate from the parietal bone by the coronal sutures, a pair of coronal sutures, and the parietal bone separate from the occipital bone by the lambdoid sutures on both sides. So this is an old slide, but now we use the Z-curve. On average, the head grows by 1.5 centimeter a month for the first 3 months of life. From the 4th to the 6th month is about a centimeter a month, and from the 7th to the 12th month of life, 0.5 centimeter a month. And when we do the rest of the neurologic exam, as far as newborns are concerned, you have to adapt a little bit because you may not be able to obtain uh, with some degree of reliability olfaction, but you can tell if they can see or not based on their ability to blink to bright light. And as far as motor exam in the newborn, this is motility and power is not rated the same way as you would with a 6-year-old. And tone and posture is also different from that of a 6-year-old. And the same is true with reflexes, and most especially these primary neonatal reflexes, the Moro reflex, the palmar grasp, and the tonic neck response. So again, mental status, going back to mental status again, um, level of consciousness is normal is awake, either and then followed by somnolence, stuporous, obtunded, or comatose. Patients should be oriented to person, place, and time. Higher cortical functions, depending on age, should be tested. Language function, practices, graphomotor, and visuomotor skills. And this is all age dependent. Now, visual acuity can be grossly assessed by the ability to follow or pick small objects or of varying sizes. And the blink reflex appears as early as 28 weeks gestation. Visual fields can be assessed grossly by introduction of non-audible stimuli from the side with the physician at the back of the patient with double simultaneous presentation. And this can be very challenging, especially to the uninitiated, but fundoscopy with practice, one should be able to determine whether the optic disc is either swollen, there's exudates, the margins are clear, if there are venous pulsations. So the pupillary light reflexes include direct and consensual pupillary reflex. Cranial nerve 2 is the afferent arm or the sensory arm. Cranial nerve 3 is the efferent or the motor arm. The afferent pupillary defect or the Marcus Gunn pupil is a lesion in the optic nerve causing slow pupillary dilatation rather than quick pupillary constriction on the affected side when consensual pupillary reflex is tested in a swinging light test. And in patients who are comatose, uh, you can also localize based on whether they are small reactive, that is diencephalic. If it's already in the tectum, then it's fixed and large. If it's midbrain, it's mid-position fixed. If it's pinpoint, then it's pontine, and that would be already at the line of death, as it were. If there is one pupil that is fixed and dilated, that means that the patient already herniated. Uh, it's called uncal herniation. This is a very bad sign. And when a patient's extraocular muscles are tested, first thing to observe would be the position of the eyes at rest and the eyelids, if they are symmetric or asymmetric, or if the patient has ptosis or lid lag. Eye movements and Dow's eye phenomenon or conjugate eye movements are elicited by 25 weeks gestation. That's very early. Vertical diplopia, meaning one image is on top of the other, is more serious and indicates trochlear nerve palsy. Horizontal diplopia is still serious, but not as serious as a vertical diplopia, and is indicative of the sixth nerve or abducens nerve palsy. So normally this is ptosis on one side, while this one is bilateral ptosis. When you see something like this, it's probably uh, either congenital or part of myasthenia gravis. So these are the muscles that move the eye: the lateral rectus, the superior rectus, the superior oblique, medial rectus, inferior oblique, and inferior rectus. When a patient tilts his head uh, in order to be able to see clearly, it often means there's inferior oblique palsy. Okay? And the Marcus-Gunn phenomenon is elicited by doing a swinging light test. When you swing one light to the other eye should constrict along with the eye that is being where the light is being shined or shown. So if you shine the light here, both pupils will constrict. If you shine a light in the middle, then it's mid-position. And you shine the light to the opposite pupil, both pupils will constrict. In afferent pupillary defect, the abnormal eye will dilate instead of constrict. So there's a sensory problem involving the optic nerve of this left eye. Superior oblique palsy also causes patients to tilt their heads to avoid diplopia. So this is sixth nerve palsy. This right eye is medially deviated because of weakness of the lateral rectus muscle, because the medial rectus is pulling it this way without the compensatory or the equal yoke muscle or of the lateral rectus. So you have pairs of muscles, lateral rectus and medial rectus. If one is weak, then it pulls in the direction of the stronger muscle, away from the weaker muscle. The trigeminal nerve has both motor and sensory components. The motor part involves muscles of mastication, and the sensory component would be V1, V2, and V3. The facial nerve um, can be a little tricky when there's facial weakness, and it's sometimes difficult to differentiate as to whether this patient has a stroke or not. But if the patient's facial weakness is a stroke, it's contralateral weakness of the lower quadrant of the face, sparing the upper half of the face. Whereas if it's Bell's palsy or involvement of the seventh nerve, weakness is on the same side, involving the entire half of that face. This is accentuated by volitional movements. One should distinguish this from hypoplastic depressor anguli oris, which is often seen at birth. It's a benign, relatively benign condition, mostly cosmetic as far as concerns are concerned, and often by the time they are 1 or 2, it disappears. That only means that the muscle is not yet well developed at birth. So when a patient cries, normally the corner of the mouth will curve downward. In hypoplastic depressor anguli oris or depressor menti muscle, the affected muscle will not allow that corner of the mouth to curl downward. So the impression is this might be the abnormal side, but the fact is this is the abnormal side. Bell's palsy, on the other hand, is when you have widened palpebral opening, flattened nasolabial fold, and the absence of creases or wrinkles when the patient is asked to close their eyes and wrinkle their forehead. So the mouth appears to be pulled to the left side only because there is no equal contraction of the facial muscles on the right side in this situation. So there's flattening of the nasolabial fold on the right, wider eyes, and no wrinkles on frowning. Sometimes facial nerve palsies may be seen at birth, many times associated with birth-related injuries in the case of, let's say, traumatic deliveries. Hearing can be tested by simply clicking a ballpoint pen or ringing a bell in infants. In older children, repeating a whispered word using or to use a tuning fork. Patients localize with eyes and head at 3 to 4 months of age. Vestibular function can be tested by eliciting the optokinetic response by holding the child upright vertically facing you, then uh, turning the child several times in full circle clockwise and counterclockwise, noting the deviation of the eyes during the turn towards the direction of rotation, and on stopping there's a quick uh, phase nystagmus, which is the optokinetic response, and that's normal. The absence of which suggests impaired brainstem dysfunction, or impaired brainstem function. The glossopharyngeal and vagal nerves involve the position of the uvula, quality of the voice, palatal movements during phonation. Gag can be absent in 1/3 of healthy individuals, but the absence of taste, the posterior third of the tongue, is not worth effort. But if they do complain of the inability to taste, then it might involve these cranial nerves. Shoulder shrugging involves the spinal accessory muscles. It is elicited in older children. The position of the tongue at rest is usually midline and deviates during protrusion towards the weak side. Fasciculation should be observed in a relaxed child and should not be uh, determined if the child is crying, especially If it's vigorous crying, then you would actually see fasciculations on the dorsum of the tongue. But if the patient is at rest and not crying, and you are able to gently open the mouth and see the tongue, and you notice abnormal twitching or fasciculations at the lateral aspect of the tongue, and that is definitely abnormal and suggestive of anterior horn cell disease such as infantile spinal muscular atrophy. In this situation, babies are usually hypotonic and weak almost at the time of birth or shortly thereafter. In the motor examination, observe very carefully their posture while standing. And you should already have noticed their gait when they are walking into the office, if they can walk or run, if there's any abnormal dragging of the legs or abnormal swing of the arms. And these observations sometimes defer examination of the actual strength of the muscles, especially in the very young patients. But if there is atrophy or pseudohypertrophy that requires more than just observation by palpations, but fasciculations can be either observed or even triggered, uh, but these are seen uh, just by observation. And when it comes to tone, in infants, you gently flap the joints like the wrist joint. You make them, you hold it at the wrist like this, and then you gently uh, flap the wrist and see if there's any degree of resistance. A scarf sign, pull to sit maneuver, vertical suspension, horizontal position, suspension are maneuvers to assess motor tone of an infant. An infant normally the first few months of life has predominantly hypertonia of the flexors of the elbows, the hips and knees, and this hypertonia decreases over time during the third month from from cephalad-caudate head to toe. At the same time, the tone of the neck and trunk increases. So this will allow the patient to be able to have a head and neck hold and able to keep the body straight while sitting. And by 8 to 12 months, further decrease in flexor tone of the extremities is accompanied by an increase in the extensor tone of the trunk. So passive tone is best judged by passive movement of joints while the patient is awake and not crying with the head straight midline to avoid influence of the tonic neck reflex. Signs of hypotonia include the scarf sign, U-shape on horizontal or ventral suspension, slipping through the armpit on vertical suspension, and head lag on pull to sit. There's no traction response. Hypertonia or increased tone is uh, elicited by passive movement of the joints with significant resistance to movement with varying degrees of posture, including ophistotonus and flexor contractures sometimes, involving the wrist, the elbows, the shoulders, hip joints, ankle joints, and even the knees. Fisting or persistent um, fisting of the hand beyond 4 months of age is usually a sign of hypertonia and is an upper motor neuron manifestation of a motor problem. So hypotonia, the baby has very poor tone and just bends in a inverted U shape when held in this position, and when you try to pull the baby gently to sitting position, the head lags and there's no traction response. The arm is just straight and does not even bother to pull itself up. And this is the uh, ventral suspension. You hold the baby upright by the armpit, and if they have good tone, they will not slide through your hands. So this is the normal full tone of a full-term infant, flexed resting posture, and that's the traction response, the uh, vertical suspension, and a horizontal suspension. So strength and power uh, are also part of the examination, and it's either the patient has 5/5 or varying degrees of weakness, 4/5, 3/5, 2/5, 1/5, or 0/5, either on one side or both sides. So you test each muscle group and try to um, put a grade into that muscle group, either left or right. And a pronator sign is also a sensitive sign of weakness. The hypotonic hand hyperpronates. There are other maneuvers like the arm roll, which can help you localize which arm is weaker than the other. And always observe their developmental motor milestones, either gross motor or fine motor milestones, if they are symmetric, if there's any preference to one side more than the other, especially before 2 years of age. So let's say if a 9-month-old grabs the bottle, puts it in his mouth, using only the left hand about 90% of the time, that means the right hand, the right arm, is weaker than the left. And you don't see that left-handedness very early in life, that means the right side might be weak. And this has happened many times in the past, and in the absence of any obvious complications during birth, during pregnancy. But when you do a CT scan, you would see old infarcts, old Malaysic changes, indicating that even before birth they had strokes. And what is seen on CT scan are old scars from these prenatal strokes. Whereas, let's say a baby is born rather complicated extraction during vaginal delivery, and the patient comes out with one arm adducted, internally rotated, with the elbow extended, forearm pronated, and wrist flexed like a waiter's tip. You know, the arm is hanging by the side, internally rotated. Um, there's no movement uh, from the shoulder all the way down, except to the wrist and fingers. So the wrist is flexed backward like a waiter's tip. So that's an Herb Duchenne's palsy. Whereas if the arm is supinated, elbow bent, but the wrist is extended, and that's a CAT1 or Klumpke's palsy, which is the more serious type of brachial plexus birth injury. Other abnormalities that you should watch out for would be abnormal movements like tremors, whether resting tremor, intention tremor, myoclonic jerks or movements, fisting of the hand, frog-like posture, which strongly suggests hypotonia of the lower extremities or even upper extremities. Usually it's generalized, and that's a lower motor neuron disorder. Whereas ophistotonus or opistotonus is a brainstem release phenomenon due to bilateral cerebral cortical dysfunction, often seen in patients with spastic type cerebral palsy. Other abnormal movements, like involuntary movements, like athetoid movements, chorea, these are all mostly basal ganglia disorders, including dystonic posturing. Tics, on the other hand, are usually transient, although they may recur from time to time, and if associated with vocal tics, then you have Tourette syndrome. So differentiate between upper motor and lower motor neuron weakness, whether it's generalized or one-sided. An example of motor weakness would be Guillain-Barré syndrome, and the lesion is often involving the different peripheral nerves, causing a demyelinating type of uh, peripheral nerve disorder, leading to ascending weakness. Myasthenia gravis, on the other hand, is neuromuscular at the neuromuscular junction. Excuse me, and often presenting with ptosis. Polio is anterior horn uh, disorder. We have eradicated polio in the Philippines. Hopefully, it doesn't come back anymore. Um, I have seen this during my medical school days. But other causes of motor weakness include Duchenne's and Becker's. And when a patient comes in with acute or subacute weakness, usually diffuse, aside from the fact you should differentiate it from Guillain-Barré, myasthenia gravis, look for toxins as a possibility, like uh, ciguatera toxin, saxitoxin. Okay. These are usually from fishes or seafood. Now, when you see this patient like this, you should, and they are boys, and you ask them to sit on the floor, they look muscular because the muscles appear to be bulky and bulging, but in fact, especially the calf muscles, that's what you call pseudo hypertrophy. There is progressive destruction of the skeletal muscles and replaced by um, interstitial material that is of no value as far as strength is concerned. So when you ask the patient to stand up from that position, they have to prop themselves up using their arms and pushing themselves up into an upright posture by pushing against their knees or their thighs to pull or push themselves upright. So that's called the Gower sign, and is seen in Duchenne's muscular dystrophy, and the weakness often involves initially the uh, proximal muscles, but eventually all muscles become involved. Whereas if the patient has hemiplegia or hemiparesis, it's usually a stroke, either acute ischemic venous sinus thrombosis or even hemorrhagic stroke in infants, for example, of 3 to 4 months of age. Or demyelinating disease can mimic strokes, like multiple sclerosis, for example. And brain tumors, depending on location, may also present with hemiparesis. Gait abnormalities, including patients with a spastic gait, they circumduct at the hips and tiptoe. Broad-based walking is usually cerebellar, often caused by brain tumors. If it's a high steppage gait with foot dropping, it's a peripheral neuropathy. A wadding gait, usually is due to a muscle disorder or a myopathy or a muscular dystrophy like Duchenne's. The patient has dystonia, normal tone while walking, but at rest. The feet turn inward and walk on the outer edges of feet. That might be secondary to basal ganglia disorders. A sensory examination, you should review the sensory dermatomal levels, and what kind of sensory exams should be done on our patients, including the Romberg's test. Tendon reflexes, normally we don't elicit the jaw reflex, but we do routinely elicit the biceps, the triceps, brachioradialis, the knee and ankle reflexes. The plantar reflex is usually S1, and superficial abdominal reflexes, T8 to T9, and T11 to T12. Try to review these milestones from gross motor, head control around 2 months, sitting around 6 months, crawling at 9 months, walking at 12 months. Rolling over in between is around 4 months of age. And also with muscle testing, individual or manual muscle testing, try to um, localize based on their um, level at the spinal cord and which nerves are involved. I do not expect you to memorize on any of this, but just be familiar in the future when you have a patient that you need to isolate more carefully which part of the spinal cord is involved. Now, cerebellar dysfunction, such as dysmetria, ataxia, and tremors in involuntary movements, can all be cerebellar in origin. Uh, it's not just ataxia, but accentuation of tremor, especially when a patient approaches the target. That's characteristic of a cerebellar problem. Reflexes, as far as deep tendon reflexes are concerned, inequalities are more common and less reliable in children compared to adults. But inequalities of muscle tone in terms of ascertaining whether it's an upper motor or lower motor neuron lesion can be quite difficult sometimes. Patellar reflexes uh, is usually accompanied by abduction of the opposite thigh. It's known as the cross adductor reflex. That should be a double D. It usually disappears by 9 to 12 months. Sustained ankle clonus is usually a bad sign and part of upper motor neuron lesion or pyramidal tract lesion. Babinski is uh, not very helpful, especially in a very young child. More reliably obtained and clinically more significant in older patients. The Moreau reflex fades out between 3 to 5 months of age. So if it's still present in 6 months and above, that is abnormal and often part of central nervous system disorders. The tonic neck reflex is elicited with the patient supine. You turn the head gently to one side. The infant assumes a fencing-like posture. For example, you turn the head gently, in this case towards the left. The left upper extremity extends and the right upper extremity flexes like so, like a fencer's posture. It is present at birth, emerges by 1 week, fully developed by 1 month, but should disappear by 6 months of age. Sucking and rooting reflexes are persistent in patients with cerebral palsy or neurodegenerative disorders, and even in adults, if they reappear, it's usually a sign of severe frontal lobe dysfunction. Writing reflexes, palmar and plantar grasp reflexes should be elicited in infants, the buttress response, the parachute response, and these can be observed if there's abnormal salivation, lacrimation, if one area is sweating more than the other. As far as the skin is concerned, if the patient's skin is pale and with cool, clammy skin, that's also a sign of dysautonomia. If there's bowel or bladder dyscontrol or poor control, that is also dysautonomia involving the spinal cord reflexes. Patients may have hypertension alternating with hypotension, bradycardia alternating with tachycardia for apparently no reason, or in Horner syndrome, meiosis, ptosis, anhidrosis, and an ophthalmos. Other soft neurological signs, uh, well, it's nice to know these, but oftentimes um, may indicate to some degree uh, some abnormality in the nervous system, especially when you have coriform movements, uh, asymmetry of reflexes, poor coordination, left-right disorientation, and synkinesia. So again, hand in hand with the neurological examination is your assessment of developmental milestones. You have gross motor, fine motor, social skills, and language. And any type of developmental delay during the first 2 years of age should be uh, part and parcel of one's evaluation of a child suspected to have any kind of neurological disorder. During the first few months of life, the usual mode of presentation developmental delay would be poor suck, abnormalities in tone, lack of visual or auditory response, motor delay, speech delay, aberrant behavior, academic underachievement, and ADHD symptomatology. And the big thing nowadays would be problems with speech delay and aberrant behavior. And this is commonly seen in patients with autism spectrum disorder. So language guidelines involve the following uh, usually by 10 months of age there is babbling and cooing and along with mama and dada. They may have one or two word comprehension. They may produce very simple syllables by 12 months of age, and by 18 months there should be a rapid increase in vocabulary. So between 2 and by 20 months, 24 months, they are able to put one or two words together or two words together, and by 3 years of age there should be a three or more word phrase or sentence. Early signs of impairment would be no giving, no showing, no pointing, less than 60 words or less than 5 words production, and no two-word phrases by 2 years of age. So, in the conclusion of a neurologic evaluation of a child, developmental screening should be performed as part of health maintenance visits. Early identification of neurological and developmental disorders are crucial to the diagnosis and management of patients with these disorders. And just because it appears to be a brain problem doesn't mean there is no solution, there's no treatment, no intervention. But because with early implementation of appropriate intervention, the chances of better outcome are greatly increased, with children attaining their maximum potential. And the only way to find out what the maximum potential is by making them go through uh, a very rigorous, scientifically based rehab process involving physical therapy, occupational therapy, and speech therapy. Thank you very much for your attention. Have a good day.